Well, when we talk about the future of endoscopy, we have to talk about the history, because we have to know where did we come from and where will we go to. And I think the most important guy is Pavis Canvin, who actually did the first scientific work on that, and who actually found and named the Canvin triangle, which is the three-dimensional entry into the foramen. And Christoph did a nice job in the live CAD lab to prepare that approach. And I think this is a very powerful approach because you can actually target intra-extraforaminal pathologies, and you can enter the spinal canal, and you can work on the bone, on the disc, and also work in the central spinal canal without taking down too much of the facets. Now, luckily we had some workup from Christoph about nomenclature. I think this is very important because when we talk about endoscopic procedures, we find so many different names for it, and I think it's the basic to have a common nomenclature. So we can actually share literature and find the procedures, know what we're doing. And I think more and more this classification comes into the science world. We have some studies which actually show that endoscopy has less tissue trauma, has less raise of C-reactive protein, less raise of creatine phosphokinase. So together with that and a low risk of complication, I think it's actually one of the smallest techniques we have at the moment to treat and decompress the spinal canal. Now, is endoscopic discectomy or in endoscope surgery getting to the next golden standard? I always try to avoid the expression that it will be the next golden standard, but I think it gives us a lot of possibilities and less invasive solutions for problems we have already in spine surgery. And if you saw the power of that transforaminal approach, you can guess that recurrent disc surgery or surgery even with implants, foraminotomy after fusion are procedures you can actually do with the endoscope in a very low invasive way. So maybe in the future we will find the endoscopy as the golden age and gold standard for endoscopic disc treatment. At the moment, I think it's just a nice tool in the toolbox, which allows you to do very minimal invasive surgery. Now, at the moment, we can actually do endoscopic spine surgery on all the different fields of the spine. Basically, we differentiate in between transforaminal and interlaminar surgery, whereas the transforaminal is a new approach and the interlaminar is a common approach we know from open or tubular surgery. And of course, when you do that surgery, you have to decide what kind of pathology is the problem. Do I have to work more on the ventral part of the spinal canal? Do I have to open up spinal stenosis? Do I have to split the flamen? And where do I need to approach the spine and decompress the neural tissue? So in fact, the only difference we have is that we have to decide before we do the surgery probably exactly where to go to avoid too much work and to avoid too long operation time. Now, when we look in the literature, we see different approaches. When we talk about transforaminal surgery, we have these far lateral approaches where we actually go in almost 14 centimeters from the midline. We have the intradiscal approach. The approach we saw from Christoph was actually the craniocaudal approach with foraminoplasty or foraminotomy. We can reach problems from the contralateral side and also work intra-extraforaminal. And the approach differs a little bit. It also differs a little bit where you enter and puncture the bone. We heard from Christoph that in some problems it's far easier to puncture the bone in the SAP, create some space by using the coronary reamers, and then place the endoscope in the right spot. Basically, we target the pathology and take away the bone which is in our way, and avoid being close to the nerve, of course. We can actually treat pathologies which are difficult, like the hidden zone pathologies, even from contralateral through the pedicle, or by reaming off the cranial part of the pedicle. Now, once we are inside, we can use diamond burrs to open up different parts of the foramen to decompress, like you see it here, the anterior caudal recess, work on the ventral SAP. What we do with those procedures is we elongate the pedicle, we create more space in the lateral recess, and we decompress the traversing nerve root. So depending on the pathology, if we have bone problems and bone stenotic problems, we need to work more on the bone. If it's a disc herniation, we have to work on the soft tissue, so less bone reaming. But when we talk about mixed pathologies with spinal stenosis, you cannot avoid to work on the bone and do some decompression in that foraminal area. When we work in the interlaminar window, we actually have to decide what size of endoscope we use. Basically, the bigger sized endoscopes are similar to the tubular techniques. We take down the yellow ligament and use it as a decompression tool. But when we work in the spinal canal, we need smaller sized endoscope, which allow us to actually work anterior, to work on the disc. With a turning maneuver, we can actually rotate the working tube and protect our nerve roots. So before you decide about the surgery, you have to know what kind of endoscope, what kind of angulation, what kind of goal is the surgical goal do I have. And depending from what is the goal, you choose the endoscope and the approach. We use the endoscope now not only for decompression of disc. You see it here. This is actually a complication of an open XLIF procedure where a small bone piece was dislocated into the foraminal area, and that problem actually was intraforaminal, of course, not 100% perfectly positioned cage. But you see with the transforaminal technique, this is a perfect solution to deal with that problem. And once you identify your cage and the exiting nerve root, you can actually take down the bone material in the intra-extraforaminal area. And I think that shows you greatly that you have already the possibility to treat some open problems with a very low invasive therapy. The same is possible if you have a slight screw displacement and radiculopathy, like in this patient. She had S1 nerve root problem after fusion, and the alternative surgery would have been to open it up and change the screw. Again, I think a very elegant solution was to take down the medial thread. This is the S1 nerve root after decompression. That's the pedicle screw, and then what I did is I just took down parts of those medial threads which were bothering and compressing the nerve root. Now, what will be the future? That's a good question, because I'm not an oracle. I don't have holes in my hands. I cannot guess it, but I think we have some problems at the moment. And one problem is the solution for dural tear. What can we do when we have a dural damage or dural tear? At the moment, we try to cover it up, but we have no possibility for suturing it. And I think this is a part where we can actually develop something together with the industry, perhaps similar to the meniscal repair in orthopedic surgery. Of course, the incidence of dural tear is the greatest when you're resecting synovial cysts, so you do revision surgery. I show you a small, one of my biggest dural tears I had, and it was actually only a few months ago. So you see this 81-year-old female patient with a 2-level stenosis. I actually wanted to do a 3, 4, 4, 5 decompression. So I started with the 1 level, and I had a good impression until I took that part of yellow ligament out. So this was actually the biggest dural tear I produced during endoscopic surgery. Interesting wise, this patient didn't need a revision. She didn't have any clinical problems, only for the first 4 hours when she was coughing. She had a little loss of urine, but she was, I covered it up after the procedure, and she was actually pain-free. But I didn't continue the 2nd level and did it 4 weeks afterwards. But when you see the amount of dural tear, actually, it's a little bit scary. So I think this is a part where we need a solution. At the moment, I try to cover it up with collagen and stick it in with that small instrument. But I think there should be either a solution like a foam or some suture techniques to deal with that. Then education. I think that's a big part. We always, when we listen to the criticisms of endoscopic surgery, it's all about the learning curve. I think we have plenty of options at the moment to train it, not only in the dry lab. We can use real spine models. We can actually use small cameras to see where we position our endoscope. We have radiolucent and radio-opaque models. And I think those things are important for the first contact with those endoscopic procedure. And there's simulation models like you see it here, where you can actually try to position the endoscope and see the field of vision. You can turn the endoscope around. You can actually see on the camera where you are. So I think those tools are very important for the future training. This is a slide Christoph gave me, and we're always discussing about it, but I think this is the right approach. In the university hospitals, you have a great surrounding for teaching. I'm always wondering if when you start the endoscopic surgery, you should start with the interlaminar approach. I personally like the transforaminal approach more because it's a little bit easier for the handling. Also, the orientation is more difficult, but I think you see you can actually stepwise plan the training curriculum and train some fellows. And I think that's great if you have the surrounding and the teaching facilities. In Europe, we always do workshops, hospitation, and then assistance for the first surgery. So when the people want to have contact with endoscopic surgery, they attend a workshop, then they look over the shoulder, and then they do their first cases. And I think what is important there is not only that you do that within a few weeks, or at least 1 or 2 months, so you don't lose the understanding of the endoscopic surgery. It's also the discussion with other faculties or other experts, which is very helpful because they can give you a nice feedback. They have questions. You can actually trust people when you talk about your complications. And I think that's very important to get better and develop the next steps for that endoscopic training. And this is just from one company, but it shows you that there's different steps to become a master in endoscopic surgery. Master would be someone who is able to do all the techniques in all the different regions of the spine. Now the fusion market, that's the next important development in my opinion, which will not only raise a lot of interest due to the financial market, but also because you can do some fusion minimal invasively in local anesthesia outpatient. And you see here At the moment, there is some development in expandable cages, but you see the limitation still. You can actually go through the foraminal area, position a cage, and use it as a fusion. You can control it with the endoscope after the fusion, and have the same control aspects as you see it here. That's the SAP, that's the implant. Here is the lateral recess. You can actually control the decompression of the lateral recess and take a look. Here's the pedicle, so the caudal part of the scope is here. Here's the pedicle line, the SAP, and you can control not only the amount of decompression, but also your neural structures like the exiting nerve root, which will come here from 10 to 8 o'clock. And again, that's what we have at the moment. We have some implants. We are getting some more and more expandable cages, but the goal would be to actually do a small incision, position your implant of about 7 millimeters through your working tube, dilate it up to, expand it up to 12 or 14 millimeters if necessary, and control it with the endoscope. And I think then we have a great solution with low trauma, and you can actually lower the hospital stay and the days in hospital. So the future, in my opinion, is great. The endoscope is only the smallest way at the moment to look at your instrument. It doesn't change the procedure, but we have the possibility to go through the foramen, which are limited in open or microsurgery. I'm absolutely convinced that once we have good expandable implants, that the endoscopic market will explode, especially in the US. I think in the combination of navigation, neuromonitoring, it's a great tool to actually target pathologies very precisely. And as I pointed out, we need some solutions for dural tear and complication management. At the moment, we use our open techniques and our principles of open revision, but I think there's still some possibilities to develop new tools. Thank you very much for your time.
We have one question from Christoph.
Hey, Ralf, great talk. You know, I know that you're not doing well because you did not mention the Wagner arch. So I just wanted to tell everybody that, you know, Dr. Wagner really was instrumental in sort of bringing the transforaminal approach to the modern type that, you know, we saw in the lab right now. And so, Ralf, that's really was a you know, in large part to you. One question I had for you is, you know, in terms of dural repairs, you know, when do you see that, because with small controlled tears like with a Caris and, you know, an inlay graft in our hands, really, I keep them overnight and then they go home the next day, but really no other sequelae. But where do you see the tear size, you know, the one that you showed, and I've had those two. I mean, where do you see a strategy, how we can sort of tackle that? I mean, where do you see, what technique should we do? Do we should bring a second port, or like?
That's a great question. So first of all, up to that dural damage, I thought when I see the spaghetti like that, I have to open up. I don't know. You know, I'm an orthopedic surgeon. I'm kind of afraid when I see the fascicles. So what she was doing, I monitored her greatly. It was actually, you saw that the rupture, it was actually like a cut, a very fine rupture which closed down when the pressure was gone. So I thought I could try it. First of all, I would monitor those patients very closely, and I only react if they have clinical symptoms like severe pain or nerve root problems or cauda equina syndrome. And out of my experience, it's probably the case in 1 out of 50 of those injuries. When you have elderly patients, and sometimes even with a small dura leak or dura damage, they might develop electrifying nerve root pain and some neurological symptoms, and then I decide to open it up. In terms of technique, I think actually the solution for those problems would probably be a second port. Because, coming from the orthopedic surgery and looking at problems like meniscal repair, anterior cruciate ligament repair, we need two hands to adequately treat those problems. There was some small nitinol coiled kind of spiral things for closing minimal invasively the dura, but I think there might be an option for suturing technique. I always think perhaps something like a foam, which you bring in, which takes a little bit of volume and seals it up, would be the easiest thing, because then it actually you actually don't have any problems in needing to suture that damage.
Hey Ralf, this is Jeff Rowe. What do you think about stapling it? Because I've seen some techniques where you can kind of
stapling is a good option, but you rarely see this dural damage as you saw it in my problem. I think in that patient, when you see it like that, even opening up, it's very easy, because it's located posterior. You have no ruptured or somehow fancy holes in there. It's just a cut. I think the most problem is when you have a dural damage in the transforaminal surgery, and it's actually anterior on the nerve root, or in between nerve root and dural sac, and it's difficult to approach from posterior. You actually have to take it all down. You cannot stitch it. You kind of have to cover it up, and that would be perfect if you had some kind of repair technique. You put it directly there on place. But to be honest, I think out of 20, only one you have to deal with those problems. Most of those small dural damages are not a problem. What I see in my experience is, because I'm treating a lot of elderly patients, a lot of stenotic patients, some of those patients, even if you go there with the bipolar probe and you normally have reaction on the my primitive neuromonitoring, as I call it, even in the elderly patients, sometimes they don't react on the bipolar, but they still develop symptoms only from small dural tears, probably because they have a less balance of nerve stability somehow. Like I did a case yesterday where I did a decompression. She had severe leg pain before, and even the small manipulation caused a nerve root problem for 24 to 48 hours. Even so, I didn't manipulate a lot. But I think those nerve roots, when they're in elderly patients and they're compressed from a lot for a long time, they tend to make more problems, almost like the myelopathic patients.
Hey, Ralf, I think, one thing is that with the small tears are no problem, but, like a kerrison bite, you just do a little inlay graft and, really that's not an issue. I think the medium size, really very get in trouble where the nerve root herniates out and then they're strangulated. And I once talked to a very seasoned orthopedic surgeon. He's like, just make it bigger. And
that's probably it could be a solution, but that's a neurosurgical solution.
All right, great to see you, Ralf. Glad you're feeling better.
Yeah, as well. Perfect. I had about 8 to 10 days flu-like. I was bound to bed actually, but made my fat face a little slimmer. That's also okay. Any more questions? I think.
No more questions. And this is sort of the end of this year's course. So hopefully next year you'll join us in person.
Yep.
And thanks all those in attendance and those online. And appreciate everyone from Seattle Science Foundation, Linda, Ashley, Tyler, Lee, Gary, and everyone else for helping to support it. Thanks again.
Thanks, everyone.
Thanks. Have a nice weekend, guys.
Thank you.